Yes, Dr. Ankush, I welcome you. You can start sharing your
Okay.
screen.
Yeah. Thank you so much, sir, for giving me this opportunity to talk about on ultrasound guided dry needling. Yes, it is uh, indeed a very interesting topic.
It's
Okay.
a pleasure, Doctor.
I will start. Should I start, sir?
Yes, please go ahead. Your screen
Okay.
is visible. Can is
Yeah,
will
yeah,
it?
yeah. Okay. Okay. So, our topic is ultrasound guided dry needling, and it is the versatile tool in chronic pain management. I
चालू
have
कर
underlined this versatile word. Hello.
Yeah.
Yeah, yeah. So I have underlined what this versatile word because we will get to know about this later. Why we have kept this topic as a versatile tool in chronic pain management. Okay. So, sir already have introduced me, so I will not waste more further time. So before we go into this topic, I would like to uh, thank to our mentor and our teacher, Dr. Lakshmi Vas, who has following the ultrasound guided dry needling for past more than 20 years. Because of her dedication, efforts, and research, we have been able to uh, practice ultrasound guided dry needling, and because of her set protocols, we have been able to uh, provide some pain relief to all those chronic pain conditions. Okay, so now to start with, this is the basic pain generators in our body, that is joints, nerves, and muscles. And we are particularly will talk about muscular component today. And for muscular component, we use two types of treatment. That is, one is Botox injection, another is ultrasound guided dry needling. And
क्या
particularly, we will talk
से
about, we will focus on ultrasound guided dry needling today. So before we go into ultrasound guided dry needling, we need to know what is dry needling. So dry needling is the treatment. Hello, am I audible, sir?
Yes, Ankush, audible well.
Yeah, yeah. So it is the dry needling is the treatment for myofascial pain syndrome, where the needle is inserted into a painful site in the muscle, which is called as myofascial trigger point. And uh, what is this MTRP? MTRP is defined as they are the hyper irritable spot within the painful taut band in the skeletal muscle, and they are associated with motor dysfunction, and characteristic referral. They are responsible for the referral of the pain. So how MTRP causes pain? Okay. So there are two types of MTRPs. One is active MTRP and another is latent MTRP. Active MTRP are spontaneously painful. They refer pain and paresthesia to the distal side. And latent MTRPs are painful only on palpation. So both these active as well as latent MTRP, they stimulate the muscle nociceptors. They disturb the motor function, and which further lead to the muscle stiffness and ultimately muscle weakness, and they restrict the range of motion. Okay. Now, what is local twitch reflex? Local twitch reflex is the pathognomic sign for ultrasound for this MTRP. And how does it appear? You can see over there. Just observe over here. Okay. Yeah. This. Yeah. This is the local twitch reflex. Okay.
Could you play that
I will
video
zoom
once
in.
again, Ankush?
Yes,
Yeah.
sir. Yes, sir. Yeah. 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 You can see over here when the needle goes through the muscle, particularly it may hit that MTRP, and that causes this local twitch reflex. That is, the twitch happens over that muscular component. Yeah. So this is the pathognomic sign of MTRPs, right? So most of these local twitch reflex are seen during dry needling. They neither be visible nor sought without ultrasound. So ultrasound visualization brings revolution into this dry needling component, which makes it more extensive as well as compressive version called as ultrasound guided dry needling, right? So ultrasound guided dry needling, yeah. So with ultrasound visualization of these local twitch reflex, they are routinely visualized in a co-working muscles, which indicates that there is the much wider distribution of MTRPs than currently assumed. What does it mean? It means there are not only if suppose there is the suppose there is a pain in the bicep and there is a particular spot where a patient complaining of pain, but it is not associated or we are confined to that particular spot. That MTRP must have involved the entire muscle. That is the co-working muscle. Co-working muscles means the bicep is the flexor, then it must have involved the antagonist, that is the tricep as well. So MTRPs in agonist muscle, that is suppose for example flexors, apparently causes strain leading to reactive MTRPs in co-working muscles like antagonists, that is the extensor and other agonists. That means muscle, when a single muscle is involved, then eventually it's going to involve all other muscles of that synergistic as well as antagonist muscles. Okay. Now, before we go into the indicative part, indications part, and role of ultrasound guided triangling into those parts, we will look for some evidences for how ultrasound guided triangling uh, is important to treat all these pain conditions. So there are two uh, evidential part is there. One is integrated hypothesis or crisis theory. Another is microdialysis study, which is done by Shah et al. So we will look for integrated hypothesis and energy crisis theory first. So at normal neuromuscular junction, there the uh, end plate potential is around 6. This is the normal neuromuscular junction I'm talking about. The end plate potential is 6. But in the area of trigger point or in the area of trigger zone, the end plate potential goes to 110s and it is called as EPN, that is end plate noise. Okay. And because of this end plate noise, there is the abundant amount of acetylcholine released at the NM junction, which causes further muscular contracture and contracted sarcomere. Sarcomere is the component where actin and myosin filament is there. Okay, so it is in the attached form. Myosin and actin filament, when they attach, they causes contraction. Now, when the muscle contraction is there, they causes low oxygen and low blood flow into that area. And because of low oxygen and low blood flow, there are no ATPs. ATPs are responsible for myosin to detach from the actin component. That means to relaxation, we need ATP. And for that, we need blood and oxygenation. So because of persistent muscle contraction, there is no oxygenation, which leads to ATP deficiency and it causes myosin actin fixation. That means that muscle becomes in a contracted state, sustained contracted state. And because of lack of oxygen and sustained contraction, that causes metabolic stress and inflammation. The inflammatory mediator starts appearing over there, and ultimately it leads to peripheral sensitization and then central sensitization. Okay. Now, when a muscular overload is there, suppose there is a pain in certain area of the muscles, and we are continuously working on that part. We are not getting any, we are not giving it any relief to that muscle. It causes muscular overload, and that leads to micro lesions in the sarcoplasmic reticulum. Now, sarcoplasmic reticulum contains calcium. Because of these micro lesions, they causes calcium release, and because of this calcium, muscle fiber goes into continuous contraction. And because of this contraction, taut band formation, and because of the taut band, we already have seen there is the end plate noise or trigger point activation starts, and then leads to this entire cycle, right? So this is a complete cycle unless we break. So at the neuromuscular junction, we have seen the neurogenic inflammation and inflammatory mediator starts to appear. Now, because of this inflammatory mediator, they stimulate the muscle nociceptor. So these muscle nociceptors are activated, which leads to heightened sensitivity of that area. And because of this, nerves becomes more sensitive, and they enhance the pain perception, which known as peripheral sensitization. So peripheral sensitization happens, which is the localized area becomes sensitized and it increases the pain signal, which ultimately involves central part, that is central nervous system, and ultimately limbic nervous system, which is responsible for emotional and cognitive aspect of the pain, which is get affected and which contributes to the more or chronic pain. Okay. So all this area is clear. Should I go ahead, sir? No. So another evidence is which is the microdialysis study done by Shah et al. What they have found that inflammatory mediators, the number of inflammatory mediators are more in active MTRPs compared to the latent MTRPs, and which is compared to the normal muscle. So what they took the sample from the certain portion of muscle, and uh, hello. Okay. So what they took the sample from this that particular affected area. And what they found there is the number of inflammatory mediators are more. Now they did the dry needling to that particular component, particular muscle, and after dry needling, they took the another sample, and within that sample, they found the inflammatory number of inflammatory mediators going down. So because of dry needling, there must be an increase in blood flow, which washed out all the inflammatory mediators, and which further leads to uh, reduction in the inflammatory mediators, which leads to further relaxation of the muscle. So this is the microdialysis study and further evidence we can see for ultrasound guided trial. Okay. Now where and why? What is the logic? What is our logic behind doing ultrasound guided dry needling or adding ultrasound guided dry needling into each chronic pain condition? So these are the basic chronic pain conditions we see as a pain physician in our routine practice: radiculopathies, neuropathies, headache, migraine, neck pain, fibromyalgia, CRPS, myofascial pain syndrome, then neosteoarthritis, and further conditions. So before we go into this explanatory part, I would like to clear that I'm not giving you I'm not telling you that that ultrasound guided dry needling is the replacement of whatever other interventions we are doing. That I'm not saying radiculopathy get treated by only by ultrasound guided dry needling. No, it is not like that. Ultrasound guided dry needling is the another mode of intervention. You can add to your current intervention, and it absolutely depends upon the basic pathology. Suppose you have radiculopathy, then you must have to do transformative injection or cervical epidural injection followed by dry needling. And why we involve ultrasound guided dry needling after doing that, we are going to see over here. Okay. So radiculopathy and annular tear. So, in cases of radiculopathy and annular tear, there muscular evidences of radiculopathy is almost found in the distribution of both dorsal as well as the ventral rami of affected segmental nerve. And because of the radiculopathy and compression, there is the irritation or compression of the dorsal rami of the affected segment, which leads to shortening of the paraspinal muscle and particularly multifidus. Multifidus is responsible for the contraction and rotation of the spine. So shortening of this paraspinal muscle occurs because of radiculopathy and innervation, which leads to further compression and narrowing of the intervertebral foramina, and which causes direct pressure on the nerve. Okay, so that is the basic pathology, and for in cases of annular tear or radiculopathy. Now we have to do. Uh, can we mute? Hello. Should I go ahead? Am I audible? And if the screen is visible?
Yes, visible.
Okay, okay, sure. Okay, yeah, thank you. So, so this is the basic pathology for and evidence for involvement of the muscular component in cases of radiculopathy. It could be both uh, lumbar as well as in cervical region. Another important factor is the when we do MRI for as an investigation part for lumbar as well as cervical radiculopathy, uh, we see this straightening of spine on MRI. This is the cervical spine and this is the lumbar spine. Now, around spine there are multiple muscles are attached to the spine, and because of the contraction there's and persistent muscular spasm which is responsible for the straightening of spine. This is the another evidence and indication for muscular component involvement in cases of radiculopathy. So we have to look for all these kind of indications to involve dry needling into this radiculopathy condition. So what we do, our protocol is we do transforaminal or cervical epidural first, followed by dry needling, and we start usually 7 to 8 days after our epidural injection. And particularly, we go for twice in a week for dry needling. Now, in neuropathy or particularly neuromyopathy conditions, so if there is a lesion in the nerve, the only way they sorry the if the lesion in the nerve, then only way to react that nerve reacts uh, for that irritation is to fire the at neuromuscular junction, and firing at the neuromuscular junction leads to more and more acetylcholine release, and it causes end plate noise, which further leads to muscle spasm, and sustained muscle spasm generates myofascial trigger points. We already have seen that. Okay, so in this is the chart which I'm trying to show what happens in neuropathic pain. In neuropathic pain, there is the lesion in the somatosensory nervous system which influence the sensory nerve, and also there is the lesion in the motor nerves. And with the lesion in the motor nerve, this entire cycle here, we already have seen that there is the increased acetylcholine discharge, which causes spontaneous electrical activity, which causes contraction and contraction and which causes actin and myosin getting locked in the contracted state, and ultimately which leads to lack of ATP and oxygen and metabolic stress, which causes peripheral sensitization. Okay, now there are two types of manifestation for in this particular area pathology. One is sensory manifestation and another is motor manifestation. Now, in sensory manifestation, there are multiple symptoms like hyperalgesia, allodynia, which occurs, and in motor manifestation, because of sudden spasm in taut band, which felt as electrical shock-like symptoms. Then sustained spasm leads to pulling kind of pain. Sometimes with persistent spasmodic condition, there has been a micro tears in the taut band, which leads to further impaired movement. Okay, the movement has been impaired, which leads to further inflammation in that into that involved area. So constant spasm of the taut band in agonist influences the synergistic component, then ultimately into the agonist, which we already have seen that. So this leads to incoordinate movement or impaired movements. So these are the involvement, how neuromyopathy component in particularly neuropathic conditions, how muscular as well as the nervous component involved and how they manifest symptomatically. Okay, so this is the basic one example I am showing over here. This is the case of trigeminal neuralgia. You can see the condition of masseter muscle over here. You can see the twitches or incoordinate movements into the muscle, and the patient has burning kind of pain over this masseter region. Okay, so this is the situation of masseter. You can see multiple contractions over here and there. We haven't done any needling to this patient yet. So this is the before needling we are seeing on first consultation. Okay. So another pathology is the multi-nerve entrapment. Through this study have shown that there could be a neuropathic pain, but not because of direct injury to the nerve, but because of MTRPs which are entrapping the nerves. Okay, so this is the another study and another component which we can see where muscular component is getting involved into the neuropathic pain, which is responsible for the neuropathic pain. No, Hilton's law. Hilton's law is particularly important for the joint, and what it says that all the motor efferents serving the muscle acting on the knee. or any other joint, particularly knee osteoarthritis I'm talking about over here, all the motor efferents serving the muscles acting on the knee, they carry afferent branches from the knee capsular elements. That means the afferent branches from the capsule, synovium ligament, they supply the efferent as a efferent limb to the motor nerves, that is the knee muscles. And why it is important for us? Because if there is inflammation, if there is the inflammation in a capsular element, which causes the reciprocal spasm in of the muscles of the knee, right? So if there is the inflammation in a capsular part in condition like knee osteoarthritis, that irritation or inflammation leads to the contraction or spasm of the muscles which are surrounded by to the knee joint, and these muscles in a spasm they commonly perceived as a stiffness. So this stiff muscle further impedes the knee movement because of a spasm, and ultimately they causes more inflammation because if you don't move, there will be a less blood supply, and if there is a less blood supply, then that means there is the more and more inflammatory mediators aggregation. So it sets up an vicious cycle of pain, spasm, pain. That means muscles, joint inflammation, which causes muscle stiffness, which leads to impaired knee movement, and which again leads to the joint inflammation. Right. So this is how muscular component getting involved in the knee osteoarthritis. So for knee osteoarthritis, what we do, we definitely you can start with uh, your intra-articular injection of regenerative therapy or genicular block, followed by dry needling. And for us, we usually start with intervention. It depends upon the KL grading. If the KL grading is severe, that is grade 3 or grade 4, then grade 4 is the surgical choice. And if the patient doesn't want to go for any surgery, then we can go for intra-articular viscosupplementation with radio frequency ablation of the genicular nerves. If the gradation is around 1 or 2, and pain is more stiffness, then we can start with dry needling only, right? So it all depends upon the severity of the patient, severity of the complaints which patient is showing, and the KL grading as well. Fibromyalgia is another common condition which we see routinely in our chronic pain practice. So in this study have very beautifully elaborated the basic pathology for fibromyalgia. What they show that there is the hyper activity of the sympathetic nervous system in cases of fibromyalgia, and which leads to disturbed sleep, and because of disturbed sleep causes fatigue and brain fog. Because of sympathetic hyperactivity, it leads to elevated intramuscular pressure, and because of this elevated intramuscular pressure, it causes muscle pain and myofascial inflammation. And because of sympathetic hyperactivity, there is the impaired healing because of they act with antibodies. So persistent autoantibodies and myofascial inflammation leads to immune complex which binds to the DRG, and which causes central sensitization. So they have mentioned that because of hyperactivity of the sympathetic component, there are elevated muscular pressure which leads to muscle pain. Disturbed sleep also causes muscle tightness. So for this particular fibromyalgia cases, if the severity is very less, severity is very more, then we usually start with Botox, followed by dry needling. And after Botox, we usually call patient after 15 to 20 days because Botox takes action time to get act. And after that, we to fine tune the effect of Botox, we usually go for dry needling, usually 6 to 7 sessions, but it depends upon the what how much patient had got relieved after Botox. Okay, so this is the role of muscular component in fibromyalgia. Otherwise, if the pain is not that much and they are not severe enough, then only dry needling will definitely relieve the symptoms of the fibromyalgia. CRPS. CRPS is the complex regional pain syndrome, and in Budapest criteria, they itself have introduced the motor component. So, in case of upper limb CRPS, they usually complaints of shock or cramping like of pain over the forearm or region. So, this is the slide where I am trying to show you the basic muscular pathology and issues over there. So, you can see over here, there are the incoordinated movements and spontaneous movements going on in muscle, and patient complaints of pain over this forearm region. So this is what happening inside the muscles, right? This is the flexor aspect over here. You can observe over here. There are abnormal activity going on over here. So for CRPS, we usually go for sympathetic ganglion block. It always depend upon the severity of the pain. If there is a pain restriction as well as pain, then we start with the steroid ganglion block, followed by dry needling of this all forearm and whatever region is involved. And for lower limb, we go for lumbar sympathetic block, but I haven't done any lumbar sympathetic block for severe CRPS. We have done with Dr. Lakshmi Vas, continuous nerve block catheter for sciatic nerve, followed by dry needling, because that patient has sudden spasmodic episode, so which got cured by this sciatic nerve block, followed by we then followed with the dry needling. And usually 6 to 7 sessions are sufficient. Sometimes you may require lesser sessions to control all these symptoms. Okay. Now, headache, migraine, and neck pain or myofascial pain syndrome, in particularly cervical region. Cervical muscles have unique property of proprioception. That means they align the position of the head with the surrounding. And suppose a patient comes to you with cervical neck pain, with giddiness or dizziness, there could be involvement of the proprioception function as well. That means uh, uh, this proprioception sensation, which is involved in these suboccipital muscles of the neck, they supply this mechanical stimulus into the electrochemical signals to the CNS via dorsal root ganglion, and ultimately CNS, central nervous system, manages the cervical muscles activity. So this cycle continuously goes on, and if there are any irritation or any impairment of the muscular component in the cervical region, then the cycle goes into a vicious cycle, which leads to further contraction and spasm. Okay, so if the patient comes to you with dizziness or lightheadedness or confusion with neck pain, then this could be the reason. You have to target the suboccipital muscles for that. And these are the various referred pain you can see over here. The trapezius referred pain to the posterior auricular region, angle of mandible or orbital region. This is the sternal head of the sternocleidomastoid, which leads to mastoid pain or periorbital region. This is the clavicular head, which causes posterior auricular and frontal headache. Suboccipital muscles, they referred pain to almost this is the temporal region. So these are the various muscles. I'm talking about particularly cervical muscle, but all over the body they referred pain to the different areas. So you have to look for that, and you have to properly examine the patient, palpate it, and you have to rule it out that if there is no cervical radiculopathy, then this could be the causative agent for neck pain. Okay. Another point is the role of posture and stress. Nowadays, many IT professionals are complaining of neck pain. So that is because of this is the upper cross syndrome and this is the lower cross syndrome. What happens in upper cross syndrome? There are the weak neck flexors and weak lower trapezius and tight pectorals and upper trapezius because of for continuously sitting in a hunchback position. This leads to the imbalance in the muscle orientation, which causes tightness in the pectoral and upper triceps. So, in such cases, if there is no radiculopathy or if the MRI is normal, if you are not able to rule out the radiculopathy or muscular component, then go for MRI. If MRI is normal, then that means this is the reason for that. Go for dry needling for all these patients, and usually they will require 4 to 5 sessions to cure the symptoms. Okay. This is some unusual cases which I haven't seen during my fellowship, but with my private practice, I have seen such cases. That is the peripheral arterial disease or varicose vein. This article from the British Journal of Anesthesia, they have beautifully explained the kind of pain in different vascular diseases. So, particularly if I talk about peripheral arterial disease, there is the ischemic pain. Okay, and how this starts? Because of the atherosclerotic obstruction to the blood flow. Now we already have seen during our initial slide our initial slides Because of the less blood flow, there is the less ATPs, and ATPs are responsible for the relaxation of the muscle because they need myosin component to be get detached from the actin component. If there is the obstruction to the blood flow over here, they results in inadequate oxygen supply to the peripheral tissue, which leads to muscle ischemia, increase in inflammatory mediators, and subsequently causes local nerve endings sensitization, which leads to peripheral sensitization, ultimately central sensitization. So this is the if you uh, uh, change your perspective to the muscular component as well, along with other component, then you can think about all these pathologies and all these areas. How are they get involved and how the patient shows the symptoms. So in cases of PAD, the patient tell you about spasmodic component. He get night cramps. He get spasmodic episodes. He is not able to walk. So in certain cases, you can go for lumbar sympathetic block if the pain is very severe. But in cases of PAD, almost all patients usually on blood thinners, though the lumbar sympathetic block can be risky for them. So I usually prefer to go for Botox injection first into these uh, uh, involved muscles, particularly involved muscles, followed by dry needling. Okay, if the stiffness is more than pain severity, then you can directly go for a dry needling for these cases. Most important for pain physician is the cancer pain or pain which is generated post chemo or radiotherapy, which induced neuromyopathic pain. So, how muscle pain from cancer pain manifest? So there could be aching pain, which is dull or throbbing pain in the affected muscle area. There could be cramping. I'm talking about only muscular pain, how they manifest or in cancer pain. Cramping could be there because of sudden or sharp muscle contraction. There could be weakness. Patient is not able to move or use the affected area. There could be burning because of tingling or burning in the muscles due to it could be because of nerve damage. And why it happens because of either direct pressure, direct tumor pressure, because the tumor could be compressing the muscle fiber, causing pain and discomfort. There could be nerve damage with radiotherapy or chemotherapy, which leads to muscle pain and weakness and spasm. There could be bony metastasis. It causes pain due to altered muscle attachment and further tension over there. And muscle wasting. In advanced cancer cases, there could be a muscle wasting. Okay. So these are the causative agents and how muscular component get involved in the cancer pain. But cancer pain is a very tricky part because cancer pain is known as total pain, which means it involves social, psychological, spiritual, and physical pain. So, for cancer pain, I would suggest you to go for all kind of treatment modalities available. Like start with medicines. Then, of course, if you can do nerve continuous nerve block or ganglion block for them, you can go with that or radio frequency ablation along with muscular component to treat muscular component, go for Botox and or for dry needling, and also involve palliative care as well because you have to cover all these aspects. Because cancer pain is not like any other pain which we treat. But this is very tricky part. So you have to include all these options available for you. Okay. So this is how we go for cancer pain. And for cancer pain, particularly, you need to go with under ultrasound visualization because there could be muscular involvement of the by metastasis or anything. So ask for MRI, look for any muscular involvement on that metastasis that involve any muscles, which usually do. So particularly, stay away from that area. Try to needle or try to inject Botox into the normal muscular area which is available for us. Okay. Perineal and pelvic pain, these are also unusual cases which we routinely see in during my fellowship as well as in my routine practice as well. So there are two kind of perineal or pelvic pain patients comes to us. In one set of patients, they have difficulty in holding the bladder, also difficulty in evacuating the bladder, that is difficulty in micturition. And all these patients come to us referred by urologists. So they already have done all the urodynamic studies and everything, and which was normal for them, then only they have referred to us. So that means that there is no any bladder abnormality or there or any other kind of pathologies there from their point of view. So what we see from our point of for us two set as I already have mentioned. One set of patient have difficulty micturition and difficulty in holding the bladder. Another set of patients have difficulty in erection, difficulty in ejaculation, and difficulty in holding that erection. Okay, and they have particularly pain areas between the scrotal as well as the between the anal opening, the area between the scrotum as well as the anal opening. So this is how these are the two types of patient we usually see in our practice. And what we do caudal injection first, single shot caudal injection with steroid as well as lignocaine, followed by Botox and Botox into this perineal region. You can see over here. This is the probe position and this is the lithotomy position for which we ask for patient to take while needling this perineal region or injecting Botox. So this is the probe position which is slightly higher up, just below the scrotal stem. And you can see this is the P. P that means the bulb of the penis, and this star mark is the bulbospongiosum muscle, and this part is the ischiocavernous muscle. Why I'm showing you all this? Because bulbospongius and ischiocavernous muscle are responsible for holding erection, causing erection, ejaculation, and holding the erection. Okay, so these muscles are really responsible and important for us because they are in a contracted state. Because of that, patient have complaints of difficulty in erection or ejaculation. Okay, and if we go slightly down, you can see over here the bulbospongius becomes thinner and ischiocavernous comes up, and this is the pubic rami. Over here is the perineal body. Okay, and below is the rectum. So we usually target these muscles. And for the first set of patients where complaints of difficulty in holding bladder and everything, we target abdominal muscles for Botox as well as neck. Okay, as well as obliques. So this is how we go for perineal as well as the pelvic pain patients, and that is our usual protocol for it. Okay. Now, other indications which I have not mentioned in detail are like FBS, that is failed back surgery syndrome or post-laminectomy pain syndrome. These patients also have sometimes that scar is painful for them. So dry needling helps to release that scar pain. Post-chikungunya and dengue myositis are very significantly improved patients. I can say they have myositis even after 10 years or after 5 years of their chikungunya or dengue. And this myositis sets with few sessions only. That is 3 to 4 sessions are more than enough for them, and they show significant improvement with dry needling. Post-hoc spasticity is also one of the good indication for dry needling. If the spasticity is more, then go for Botox first, followed by dry needling. Post-herpes neuralgia, then cervical dystonias are also important. Cervical dystonia, we usually tend to go for Botox first, and we are not in injecting into a single or only three or four two muscles. We tend to inject all those cervical neck muscles of the affected region as well as the non-affected region in a distributive manner, followed by dry needling, and then other cases as well. Okay, so this is the indication and our routine protocol for basic pain conditions, what we usually see in our routine practice. Now, a little bit about technical part of about ultrasound guided dry needling. So how the needles look and size of the needles, how to do them, and what pre-medication or preparation we require before each session, and what is the frequency and duration we do for dry needling. And we'll discuss two cases where I have which I have for which I have done only dry needling for them. So we'll discuss all that. So these are the needles. And this is the different size of the needle. They start from 13 millimeter, that is 1.3 centimeter, 2.5, that is 25, 40, 50, 60, 75, 100, and 120. 120 is the 12 centimeter needle, which we hardly use. Suppose the patient is bulky. So in buttock region or posterior thigh region, we go for this 12 centimeter needle. Okay. And 13 centimeter needle also we rarely use. we use this for particularly targeting the intraosteal or lumbricals muscle. Routine use, you can go for from 25 to 100. These are the basic required needles. Okay. So what is the preparation and pre-medication? Pre-medication. Can you sir, can you mute all of them? Okay. So what is the basic preparation and pre-medications which is required before we start for dry needling? So if the patient comes to you for for consultation and you have decided to go for dry needling, so always start with medicines. And I usually prefer to go for pregabalin once in a day, that is 75 to start with during evening hours, and myospas twice in a day. Before at least for 5 days, because that will reduce the muscle tension or any kind of sensitization over there, which will help us uh, for our needling. It will be not that kind of not so much painful for him. So you have to decide and the area and part of the patient, which area you want to start for dry needling. You have to decide that first. Then you can apply priloxine, that is prilocaine as well as the lignocaine over that over the skin, which of the area you have decided for dry needling, at least for 30 minutes. Along with, you can go for TENS, that is the transelectrical nerve stimulation, with or without. If your setup has this facility, then go for that. And after half hour, clean the pylosphere, and then you can start the dry needling. And you can use betadine instead of jelly. If the stress level are high for a patient, if or he's having any fear of needles, then ask the patient to take myospas or any other painkiller 2 to 3 hours prior coming for needling. If the anxiety level is very high, then you can ask the patient to take pregabalin before coming here, but he must be accompanied with someone. Okay. Basic pre-medication and preparation, it is required for dry needling. Okay. So how to do it? Now, just before I start these videos of a demonstration, just observe all these things. So first, you have to choose the proper probe for visualization of the muscles. So this is the calf region needling I'm doing over here. And you can see the patient is bulky, so I am using this curvilinear probe, right? And for the calf region, for example, I'm talking about, for the calf region, you can either go out of plane, that means you can go perpendicular to the muscle or you can go parallel to the muscle. What I mean by perpendicular, for perpendicular, you will target gastrocnemius, soleus, tibialis posterior, and then tibialis anterior. And in parallel, you will target gastrocnemius or soleus muscle. Okay. So I will start this video, and I'm using betadine as a medium for that. So here we are targeting the gastrocnemius and soleus, right? In a parallel, in plane approach. So either you can come from lateral aspect or you can come from the medial aspect. Okay, to target gastrocnemius and soleus. You can also observe the tap we are giving for introducing the needle. Okay, so now what we are doing, we are trying to adjust the depth of the needle so that we can target and we can involve the targeted area. Okay, that's it. Now here, what we are doing, we are again targeting the calf muscles, but in out of plane. Just look at the way how we are tapping the needle to introduce it. Just look at the way. Okay, that's it. Yeah, like this. We have to tap it like this so that it will not be that painful for a patient. So we have targeted the gastrocnemius, soleus, tibialis posterior, and tibialis anterior. We need to adjust because it may hit bone or it may hit any vessel over there. So will properly adjust it and go down distally. Now, frequency and duration. How long can we keep the needles? We usually keep the needles for 25 to 30 minutes. This is sufficient for a patient because when a patient comes to you for dry needling, you have, suppose you are targeting back or back of legs. So that patient must lie in a prone position while applying the Prilox. We are keeping Prilox for 25 to 30 minutes. Then we are doing the needles for doing the needle of back as well as the back of legs. It will take 15 to 20 minutes. Okay. And after that, we are keeping the needles for 25 to 30 minutes. That means that patient is lying in that same position for almost 1 hour, right? So 1 hour is more than 30 minutes are more than sufficient for keeping the needles. Then after removing the needles, you can ice pack over the area of needling, and patient can go home and also do it once again. We usually do twice in a week with 3 to 4 days gap in between. And whenever patient comes for the second session, we tend to target the alternate area. What I mean by that, if the patient of suppose the patient of radiculopathy comes to you and you have done the transforamen epidural injection and facet injection, whatever, and then you want to start with the dry needling sessions. Okay, so for the first session, you start with back, lower back, buttocks, and back of legs. Okay. To start with, you can involve only one limb if that is involved. If the both limbs are involved, then you can involve both the limbs. When the patient comes for the second session after 3 to 4 days gap, you have to target the front of the legs. Okay, not you should not involve the same area again and again unless the patient have more pain even after first session. Then you can target that. But usually we alternate with each sessions. Okay, if the patient have very less or not so severe pain, then once a week is more than sufficient for them. Suppose in cases of myofascial pain, once a week is more than sufficient. Primary or secondary intervention. Now it depends upon your choice. If the needling is primary intervention or secondary intervention. What do I mean? If you have done other intervention first, then the sessions or the area it will vary because of primary intervention we already have taken out more of his symptoms and pain. So it depends on which area is remaining. So you can target accordingly. If dry needling is your primary intervention, then definitely you start with the affected area followed by other areas. And please don't use the same needles. You use once and then throw it. So, just for example, I'm showing you the how we usually target the back and which muscles we target. So this is the case of radiculopathy. We have done the transforaminal epidural and facet injection for her, and then we ask her for dry needling. So this is the central part, and for spinalists, we tend to needle just 0.5 centimeter from the midline. To target longissimus, we go few centimeters from the midline. To target QL, that is quadratus lumbar and iliocostalis, few more centimeters to go. And per needle should be go in perpendicular position. You can target spinalis longissimus in incline approach as well, but better to go with perpendicular, that because that will involve more and more depth of the bulk of the muscles. And for psoas, you have to go more laterally. And for targeting the psoas, what you can keep your probe parasagittally like this over here and look for trident sign, which we look for while in ultrasound. Trident sign is the transverse processes, and between those transverse processes you can see the psoas muscle. So you can target that in out of plane, and for that you will require 75 to 100 centimeter needles over here. Now this is the buttock region. That is the bulkiest part. You need 100 or 12 centimeter in the bulky patient. So we are targeting Gmax or G medius over here. This is the back of thigh. We are targeting hamstrings over here, and most of the needles are perpendicular. Okay. This is the calf region we target over here, peroneus from the lateral aspect, and over here, perpendicularly, we are targeting gastrocnemius, soleus, tibialis, posterior, and anterior. We have seen that in demo video, right? And for the neck, for a neck region, you have to target all these deep cervical muscles, that is semispinalis, splenius, and inferior obliquus, trapezius over here. This is the part for sternocleidomastoid. And rhomboid also you can target over here. The rhomboids, for rhomboids you can just keep the probe like what we keep for erector spinal block. That is the same way you can target rhomboids muscle for dry needling. Okay. So for example, I'm giving you the algorithm for back needling in average depth for patients. So we start with spinalis and multifidus. You can use 4 centimeter needles perpendicular, that is out of plane, and 0.5 centimeter paraspinal. For targeting longissimus, you can use 50 for 2 to 2.5 centimeter paraspinally, iliocostalis and QL 60 or 75, and psoas 100. Okay. And on an average, 20 to 30 needles are inserted in the back. It depends upon the patient tolerance as well. If the patient is not tolerating, you can reduce the number, and always perform the needles under vision. And for buttock, Gmax, Gmedius, piriformis, we use 100 to 120. Again, it depends upon the bulk of the muscles, and obese patient will require higher, longer needles. Back of thigh, adductors, bicep femoris, that is SMST, and vastus lateralis, you can use 100 centimeter needles, 10 centimeter needles. And for legs, 60, 75 is more than sufficient. But for thin lead patient, you can use 40 centimeter needles. Now we will discuss some cases. So I have involved 2 cases over here for which I have done only ultrasound guided dry needling for the treatment. Okay, so first case is the linezolid induced peripheral neuropathy. She's 18-year-old girl. She's diagnosed with multi-drug resistant TB who developed peripheral neuropathy following 3 months of linezolid treatment, that is 600 mg. And her complaints were tingling and numbness over the dorsal and plantar aspect of the both feet. Okay, please try to focus over a dorsal and plantar aspect of the both feet, along with pain in the medial aspect of the toes, burning sensation on the plantar aspect. Okay, the pain was continuous and which was aggravated by walking or touching to the ground. And intensity was like 3 to 4 during the daytime, but nighttime it is increased to 7 to 8, and which is significantly disturbing her sleep. The patient's mobility was severely limited because she was not able to touch the ground properly or walk properly, which with walking restricted to 5 to 10 minutes, and standing tolerance limited to only 10 minutes. Okay. So you can just observe over here. Look at the way she put her foot on the ground. You can see over here. She is not able to pull her foot on the ground properly. She has pain over here, medial aspect as well as the foot. Now see. Also, she is not able to walk properly, losing her balance. Observe over here. Yeah. So I wanted to start with pulse radio frequency option for her, targeting common peroneal, TBL, posterior tibial nerve, to cover the area uh, which is involved in her. But because of some issues, she was not ready or not able to go for that treatment. So I decided to go for only ultrasound guided dry needling. And to show you the condition of the her calf muscles over here, just look at this. This is the calf muscle. I have introduced the needle over here, gastrocnemius soleus and lateral aspect. Just look at the LTRs over here. See, so this is the situation of her muscles while doing the needles, and this is the reason for her complaints, right? So I have done around 2 to 3 sessions first, at which gave her 50% reduction in symptoms and 70% decrease in burning sensation, ability walking ability has improved significantly. She could stand for more than 3 hours, more than an hour. Resting pain reduced to 2 from 4, and night pain reduced to 4 from 7 to 8. So I continued for 5 more sessions, which results in further functional improvement. So this is the her improved walking gait. You can see now she was walking properly after needling sessions. Burning has gone down. She has started on a saving machine for 3 to 4 hours. Then more, she has increased working for 5 to 6 hours. No night pain, no aggravation pain for her. So this is what we targeted for uh, muscular component for her symptoms, and we got the results over here. Okay. Another case uh, is the 73-year-old cardiologist in Mumbai, and he has chest pain on the left side over here, this part, this part, and which is aching in nature since many years. Sometimes that pain got aggravated with talking for a long time or breathing, and pain was intermittent in nature with severity 5 to 6 out of 10, and sometimes it lasts for a few minutes, sometimes longer. So this pain has started after angioplasty, and after angioplasty, when patient started complaints of this kind of pain, he has done all the investigations like cardiac and respiratory involvement, because he himself was he's a cardiologist. So 2D echo, angiography he has done, all were normal. There was no any causative agent for starting this pain. So what I did, I just asked him to go for ultrasound examination, and what we found on ultrasound exam. So this is the affected area, that is the left side, and this is the normal area, that is the right side. You can see over here, this part is the ribs. These are the ribs. This lower portion is the pleura, and this is the muscular component. This is the muscular areas. And with compared to the left side, which is affected area, these are the ribs, and see the pleura. Pleura is way above from the normal side, and this is the muscular component. Okay, and I have kept my probe over here on the both the side. Okay, so this is what we observe. We observe that muscular depth or bulk of the muscles on the affected area is almost 1 centimeter lesser than the normal region. You can see the muscles in a relaxed pattern over here, and you can see the muscles in a contracted or in a spasm over here. So I assume that this could be the causative agent, and I wanted to start for go for dry needling for him. So before that, I have started myospas, and with myospas, plain myospas, he had relief 10 to 15% relief, which was diagnostic for me to start with dry needling, and then I have started dry needling for this affected area. I have introduced few needles here, this involve these particular areas with somewhere I think 2.5 centimeter and somewhere like 4 centimeter needles. And with first session, he got 50% relief, and I did only 2 more sessions for him, 2 to 3 more sessions, and he was completely pain free. Along with improvement in breathing and talking, there is no aggravation of complaints. So that is how we involved ultrasound for diagnosis, and we got the results. Okay. So to conclude, we need to take complete history and decide our plan of management based on the symptoms. If you want to go for any investigations, go for that to rule out any pathology. If only myofascial component is involved, then go for dry needling, or if you want to go for any severity, then go for Botox or trigger point injection, whatever. You have to decide that you based on the symptomatology, and then later on you can involve dry needling to uh, improve the further relief. Ultrasound guided dry needling, then based on the symptoms, ultrasound guided dry needling can be your primary or secondary intervention. Thorough knowledge of sonoanatomy is really important for us to do dry needling because we don't want to hit any nerve or vessel and we don't want to get into trouble. So dry needling, for dry needling, ultrasound guided dry needling, you need to have sonoanatomy as well as normal anatomy knowledge is really important. And it is a continuous process. It is not like that you will get in few sessions, but it is a continuous process. You get to learn with every patient. And to start with, if you decided to go for dry needling, always start slow, involve less area and involve less needles. Suppose the patient having complaints over the nape of neck, just involve that area, involve less needles. For the nape of neck, target trapezius, or target levator subscapularis. Okay, these sufficient for you to start with. Now, why to convince bit challenging? What why I have written over here because you need to convince your patient first why dry needling you are going for a involved dry needling for him and what is dry needling because sometimes patient may confuse it with natural therapy or any ayurvedic treatment, but we are not doing any ayurvedic treatment. It is completely pathological and allopathic treatment we are doing. We are targeting the muscular component. So if you are clear with yourself that why I'm doing dry needling and why his symptoms allowing me to use dry needling or muscular component, then only you can explain to your patients properly. And then if you are able to explain him properly, they will understand. They will definitely go for it. Okay, so that is how convince is a bit challenging, but that depends on how properly you have understood the symptoms of the patient. So you have to be clear with yourself first. Okay. So journey towards a deeper understanding of musculoskeletal pain, it begins with clear visualization of the underlying structure. So uh, that is how we started with ultrasound guided dry needling to visualize the underlying aspect, that is the underlying musculoskeletal component for pain as a for generator of the pain. So if we keep that perspective in our mind for any kind of pain condition, we will definitely able to sort all those symptoms patient comes with, and we will able to able to give him more sustained relief. Because with dry needling, you are not only reducing the pain, you are also improving the disability. That is what these are the positive factors for dry needling. And that is why I have highlighted this versatile word in our topic that ultrasound guided drainage is a very versatile tool in chronic pain management. Okay.
Wonderful, wonderful, Dr. Ankush. Amazing presentation. I'm
Yeah.
sure all of us would agree that
Thank you, sir.
ultrasound guided dry needling is definitely a versatile tool in chronic pain
Mm.
management and a versatile tool to have in our arsenal as well of the pain
Yes,
intervention. I really
definitely.
liked a few points of your presentation. One was the amalgamation, what you did between, telling that this is an allopathic treatment,
Yeah.
naturopathic treatment, because many patients will get confused. And the most
Yeah,
important thing,
yeah.
take away,
Routinely, they ask you, is it
yes,
acupuncture or is it like naturotherapy? That
true,
is
true.
what the kind of questions we usually get. That's why I have explained.
I mean, nowadays when we explain epidurals also, they're asking, is it allopathic or not? So for dry needling, I think definitely they'll ask. But definitely, I feel it's very important. Convincing the patients, making them understand in your consultations is what is primary importance. And wonderfully, you have demonstrated all the examples of patients. And I have to comment on the ultrasound videos. They're really good, really well labeled, and very easy to understand, right? So now I'll open the platform to questions. If anybody has questions, kindly feel free to ask them. Okay. So even our international delegates as well, if you are having any questions you want to ask in Bahasa, we have Carly with us who can help you to translate and we can ask the questions.
Hello, sir. Good evening, sir.
Hi, Dr. Santoshi Lakshmi. Yes.
Yes, sir. Good evening, sir.
Good evening. Good
Thank you,
evening.
Dr. Javed, sir, for conducting such a wonderful webinar. And I congratulate Dr. Ankush, sir, for such a enlightening It's such a very good topic about dry needling because I had no idea about dry needling at all. And sir, I have a question for you,
Please
Dr.
go ahead.
Ankush, sir.
Yeah, tell me.
Sir, like as you said, what is the exact place of dry needling? Because suppose trapezius it is such a big muscle and rhomboidus and all that. Where exactly we
Yeah,
have to put the needle?
yeah, I'll show you I have the slide over here. I can just explain it. Yeah. So now I have already have mentioned that suppose the patient complains of pain of over here, that is the nape of neck, but that doesn't mean that pain area is confined to this region only. That
Yeah.
must have included entire muscle. So you have to target from here to here. Now, when you go to the suboccipital region, the thickness of the trapezius is very small. It's like a thin layer.
Mm.
When we come
Yes.
down, then the bulk goes up. So you have to target the entire part of trapezius. You can now, when I put needles over here, you already have targeting trapezius from these rhomboids for these rhomboids as well as this part. Okay, so try to involve all those area and all the involved areas with addition, like because uh, when pain occurs, it occurs in a chain. Suppose the patient has complaints of neck pain, then that must have included this part as well as this part, and it goes down. Most of the patients of myofascial pain complaints of complaining over neck, then shoulder, then arms. So it occurs in a chain. So myofascial trigger involves entire muscle, synergistic part as well as antagonist part. So you have to target that. So what I mean by that, suppose you have done the needle for trapezius for neck pain over here, this region you have involved to start with the confined area. Then for the next session, go for scalene muscles because these are the antagonists for the trapezius involved, right? So you have to start with involved area and try to involve entire muscle if you have found. And with ultrasound, you can definitely see some LTR or any twitch reflexes over there. That means you are in a proper zone and you're targeting the causative agent. Okay.
Okay. Sir, and after 8 sessions, like after 5 to 6 sessions, how long the pain it's going to get relieved for how many months?
No, this is like this depends on patient to patient. Suppose only myofascial component is there, then you may not require 6 to 7 sessions. Patient may get relief after 4 to 5 sessions only, and that will go for more than 6 months or year if there is any injury or any history of fall, then only then pain can reappear. With proper physiotherapy and maintaining the posture, you can give him relief for longer duration. Suppose there is any pathology like uh, nerve root radiculopathy or annular tear, then you already have given the steroid injection for him that will sustain for 6 months or sometimes a year. But along with that, if you have added dry needling for them, then definitely it will go for more than a year, unless
Mm.
again if there is any injury to the spine happens.
So what is the cost of the needles and which companies like they are marketing?
So it depends actually. So this is what I have, and for 1,000 or 1,200 rupees, I get all those needles from 25 to 100, that is 10 centimeter, uh, and each box contain more than 100 or 200 needles. So you will not require all these needles, and you don't need to go for 100 or 120 needles to put this number of needles to start with. You can start with 20, 30 needles in single duration, in single session.
And sir, this Prilox application, because in this case only such a larger area is involved, is it safe to apply such a big area of Prilox ointment, sir? For
Uh, as a protocol, we used to apply Prinox to reduce the
for such a large
sensitization of the
area, sir?
skin. Yeah, you can apply, but for my own practice, when I treat uh, some not so affordable patients, I will not go for Prilox because that is very costly cream. So I will
Yes,
just
yes, yes.
clean this affected area with sterilium twice, and then I start with needling. And when you use new needles each time, then it will not be that painful
Painful. Ha,
because
ha, ha.
yeah.
Mm.
So you can go
Okay,
with
sir.
only sterilium, twice application of sterilium and cleaning that area. That is sufficient for him.
Nice. Thanks a lot, sir. Thank you very much.
Yeah, thank you.
Okay, so anybody else, if you're having doubts, please unmute yourself and you can ask Dr. Ankush.
Hello, sir.
Yeah.
Yes.
After placing the needles, you told we have to keep the needle in place for 15 to 20 minutes like that.
Yeah,
So
25 to 30 minutes. Yeah.
what is the reason for such durations?
There is no particular duration which we have mentioned, but this is what we have found that is more than sufficient because what needles do, they needles do, one is the when needles is introduced into the muscle, they causes micro tear and micro bleed happens, and from that micro bleed growth factors which comes out and they can help to reduce the inflammatory mediators. Another thing is they improve the circulation. So for that reason, 25 to 30 minutes is more than sufficient. Another thing is that suppose you are doing dry needling for back and back of legs. So you have to keep that patient in a prone position. If you are applying the Prilox for half hour for that thing, while doing the needling, it will take also 15 to 20 minutes. And then after that, you have to keep the needles for 25 to 30 minutes. So 25 to 30 minutes is the approximate duration for which the symptoms get relieved to reduce the contraction of the muscles. That is what we have observed. In certain patients, we can keep needles for 40 minutes, but only it depends the tolerance of the patient. So I'm trying to convey that this is the on an average duration we keep. For if you keep for a shorter duration like 10 to 15 minutes, then that will not be effective. So on an average, 25 to 30 minutes is more than sufficient for a patient to start affecting to have the effect of dry needling.
Okay, sir. Thank you. And one more thing for fibromyalgia, the patients will be having
Yeah.
almost from head to toe everywhere. It will be
Yes,
painful.
yes, yes. So
So,
yeah, to start with fibromyalgia, you have to ask the major complaining area, and you can alternate with in different sessions with the areas. Suppose the neck pain is more, then for to start with the neck pain, neck areas. Then for the next session, go for you have to take the follow-up for the reduction of the symptoms after first session. Then for the next session, you can go for legs. If the sometimes patient himself or herself tell you that I'm feeling much better, we can go for another session of the neck. Then that also depends. But for as a protocol wise, you can alternate the areas in each session.
okay, sir. Thank you, sir.
Okay. Thank you
Hello.
for this, Dr. Ankush.
Hello.
Yes, yeah, Dr.
Hello.
Divya.
If we are choosing large area, then how much should be the distance between the two needles?
How much distance? Okay, I will show you.
Between the two.
Yeah, okay, you can see over here. You can see over here. So if your target now, this is the largest area we are choosing because we are putting almost 30 to 40 needles in the lower back. So while what is the when you use ultrasound, suppose you are doing at L1, L2 level. Okay, you are going with L1, L2, L3, L4, L5. So you have to target each area, and at each level you have to target each muscle. Suppose L1, L2, you have to target spinalis from both the side. Then you have to target longissimus, iliocostalis, and quadratus lumborum, which comes lower. So distance, it depends the affected area. So on an average, which each level you can keep the distance between 1 to 2 centimeter for each needle. If the area is painful, then you can put some more needles into that area.
Hello, Dr. Ankush.
Yes.
Is there any, in your experience, is there any pain, chronic pain, in which you have seen that dry needling does not work that well?
There are certain cases, ma'am, like in knee osteoarthritis, very tricky one. Why? Because in higher grades, that is scale grading 3 or 4, those are surgical cases. Because of involvement of muscular as well as the joint portion, we have started with regenerative, and we have given him all the genicular ablation, and we have given him we have sessions of 7 to 8 sessions of dry needling as well. That was the grade 4 patient I'm talking about. But he didn't get much relief even after that. So these are the certain conditions, more what should I say, more surgical kind of cases or more chronic kind of cases are difficult to handle.
Okay. Thank you. And for sciatica, it has, I mean, if it is not particularly radicular pain, but referred pain, as in from facet or something like that, for that
Yeah.
it works
In
very.
those cases as well, yeah, it will work. It works wonderfully well. Only you have to start with facet injection or SI joint injection first, followed by dry needling.
Hmm. Hmm.
Because
Yeah.
for facet as well, they appear as the band-like pain in the waist and then sometimes over the anteroposterior thigh. So that means you have to include all those areas.
Hmm. Okay. Thank you. Sorry, can you also show some more example of if you have like of neck dry needling?
I think I have. So yeah,
Yeah, this one we saw, yes.
yeah. So I have two photos
Okay, okay.
yeah, right now. Yeah.
So
So I
just
can explain.
approximate,
So
please
I can
do.
explain the case over
Yeah,
here. She's
I would love to. Thank you. Please do.
yeah. Okay. So she's 17-year-old girl, and she was the chess champion, national level chess champion, and she used to practice for 6 to 7 hours for her chess, and she completely focusing on that her game and her practice, and which leads to persistent neck pain because of focus and eye pain over here. So what we started with Botox first because her neck muscle were completely into a spasm with persistent sitting and focusing and sympathetic hyperactivity maybe. So we started with Botox of all those areas, that is the suboccipital region and the neck muscles, trapezius, rhomboids, sternocleidomastoids, scalenes. Okay, and
Mhm.
after that, 15 to 20 days, we started with the dry needling too, including these areas. So one session with this, one session we keep patient in a lateral aspect to target the sternocleidomastoid and the scalene muscles, and sometimes this shoulder region as well. In another session, we keep the patient in a supine position to target the front of the neck to sternocleidomastoid, pectoral region as well. Because when there is a chronic pain which starts with
Mm.
the neck, then it tend to involve the back of the neck as well as the front of the chest as well. So we have to target every aspect over here. So that is how we do, and that is also patients tells you which area to target.
Okay. Okay.
Yeah.
Thank you.
So,
Hello.
Yes.
Yeah. So any any uh any other questions for Dr. Ankush? I'm seeing that the chat box also there's nothing much.
Yeah.
Yeah.
You can
So I
asking for
think
the
then
feedback in that.
yes, that just
Yeah.
do that.
Yeah.
So I'd like to then I think we can conclude, Dr. Ankush.
Yes, sir.
So I'd like to again thank you very much for a wonderful presentation. And I'd like to tell you that this webinar of ours has been the biggest hit. It has had the highest number of participants. We have reached 100 participants. So a big round of applause to you and to all our
Thank you.
participants for joining
Yeah.
in. And it was a wonderful time. I'm sure nobody felt that it was very long. That's the reason why we are still having 100 participants still.
Yeah, okay.
So it was a very engaging presentation, from your side.
Thank you.
And this topic itself is very wonderful and beautiful.
Very engaging. Right, right.
I'd like to thank all our delegates for taking out your precious time on a Sunday and joining us. I'd like to thank Carly for coordinating, co-hosting this with the international candidates, and the man of the moment, Dr. Ankush Vasnik. Again, thank you very much for
Thank you so much, sir,
agreeing to
for
be a part
inviting me.
of the webinar. And I'm sure this will be the beginning of further collaborations.
Right. Right.
Thank you, Dr. Ankush.
Thank you so much. Thank you so much, sir. Thank you, everyone.
Thank you.
Yes.
Okay. Good night, everybody. Thank you.